I think multiple myeloma is a multiclonal disease, and targeting with different mechanisms of action would allow us to get the best possible outcome for patients. So to your question about which exactly mechanism of action helped the most, the design of the study suggests that the addition of Isatuximab to VRd improves the outcomes, both in depth of response, but also in progression-free survival, and a good trend for overall survival at this point. So targeting the disease early on with different mechanism of actions might allow us to get to these responses and these long-term outcomes. The fact of the results of this study, the addition of Isatuximab to VRd in transplant-ineligible patients, I think it gives this patient population the opportunity, the option of considering this type of treatment. We were a little bit concerned about adding, especially for transplant-ineligible patients, but the results of the trial suggest that the benefit is there. We were actually surprised to see how long patients stayed in this treatment. As you say, the median duration of treatment for Isa-VRd was 53 months versus 31 months for VRd. We thankfully collected data for quality of life, and at least the primary endpoint for that assessment has been released as well at the presentation, but also in the manuscript, and there's no detriment in quality of life in that particular questionnaire. We also collected information about healthcare utilization, but we haven't analyzed the data yet. It is interesting to think that if you don't progress, you might not utilize some things. So we will try to evaluate in more detail those data in the near future. When we do subgroup analysis, generally the statistical idea is to understand if there is a consistent efficacy across different important subgroups. To your point, we were very happy to see that it was consistent across ages, of different ages of subgroups. So we tested more or less than 70 years old, but also we tested 75 to 80 years old. And the effect, the beneficial effect in PFS and depth of response seem to be very consistent across those ages. Also, I have to point out that there is also consistency with one of the staging systems, the RISS, for the high-risk patients in that particular staging system. Across the most of the subgroups, we could feel very comfortable saying that the effect was there and with a consistent result. No unexpected safety effects. It's good to see that the profile for VRd and then Isa-VRd is what we would have expected by including both in a regimen. We haven't seen any particular concern, especially because of what we were talking about, the exposure, right? And we try to understand if that additional absolute approximately 20 months of additional exposure explains some numerical imbalances in some of the description. And it appears that most of it has to do with how long patients stayed on the treatment. So we're happy to see that the benefit risk appears to be favorable for Isa-VRd despite this very long exposure. Yeah, we have a pretty large program actually. We have, you probably have heard that we collaborated also with the IFM, and there was a release of the data of the benefit study where the IFM actually tested a different dosing schedule for bortezomib in this Isa-VRd treatment for the similar patient population, for the same patient population, right? We also collaborated with the German group, and we had in 2021 the primary endpoint of MRD negativity post-induction in transplant-eligible patients. We're looking forward to seeing next data readouts in the upcoming months or year, right, for PFS of that, Isa-VRd in transplant-eligible induction. That study is very interesting. After transplant, there is a second randomization, and then we test Isa-lenalidomide versus lenalidomide. So we would have two different questions answered with that trial. We talked last year in December about Isa-KRd for transplant eligible. We are collaborating with EMN on that. And indeed, the primary endpoint of MRD after post-transplant consolidation was very encouraging. So we have several regimens. We collaborate a lot with cooperative groups to improve the understanding of how best to administer this regimen. And many people might have heard that we are looking also into moving to Sarclisa to subcutaneous delivery, and we have an entire program trying to ensure that we have data for providers, for patients, on how that subcutaneous delivery of Sarclisa goes with most of our combinations as well.